The Move, Look, and Listen podcast with Dr. Doug Stephey is brought to you by Audible. Get a free audiobook download by visiting audibletrial.com/inbound. We'll have a link in the episode notes for your convenience. Many of the books mentioned here in the podcast are available in Audible. Sign up for a free 30-day membership trial, and you can download any book you like. Support the Move, Look, and Listen podcast with Dr. Doug Stephey by visiting audibletrial.com/inbound.
If our two eyes are not working together well as a fast, synchronized team, our internal map quest continues to be off. It's consistently inconsistent with our ability to judge time and space. Those that don't feel well grounded, those that have some measure of anxiety, oftentimes it starts in the visual system. If you can't move, look, and listen in a fast, accurate, effortless, sustainable, age-appropriate, meaningful way, you're in a world of hurt. There's a whole world in vision and how it affects brain function that no one's ever shared with you. 2020 is perceived as the holy grail of going to the eye doctor. Well, I'm here to change that paradigm. Welcome back to the Move, Look, and Listen podcast. I am your host, Dr. Doug Stephey. I'm blessed today. I mentioned before we started the recording that I really feel like a kid in the candy store today because our guest is Dr. Arnold Wilkins. I've been following his body of work for probably 20 to 25 years. He's a prolific author and publisher, and arguably what he has done over the last 30 years or so has dramatically changed the way that I practice every day in my optometry practice. So, Dr. Wilkins, welcome to the show, number one. And if you want to, just give us a brief background of who you are and what you've been up to.
Well, thank you. I'm a psychologist. I started life as studying the psychology of memory. I don't suppose you want my entire life story, but I did a postdoc at the Montreal Neurological Institute, which was a wonderful place. And there I was asked to see a patient who had seizures whenever she looked at striped lines. And that got me intrigued. And I spent the next 20 years looking at what it is and what it isn't that provokes seizures. And it turns out that people are not only sensitive to flicker, they're sensitive to patterns of stripes.
Well, I think that's one of the most fascinating things to me. When I have a discussion with a patient and we talk about how evil fluorescent lighting is and how they can't stand it, I then bring into the discussion about the alternating black and white stripes and that they electrically tend to do the same thing to the brain that flicker does. And that always comes as a great surprise because patients generally don't know that.
Well, the sort of pattern on the escalator stair treads is probably one of the worst. And they evoke seizures in those unfortunate minority of the population who are liable to seizures, but they also provoke discomfort in most people, actually, to a degree. But anyway, that's what got me interested. It was a long time ago now.
Right. It started out with the seizure activity.
Yes.
And then was it migraineurs next that you had a closer look at?
It was a bit of both, actually. We managed to show that the sort of visual stimuli that provoke seizures also provoke discomfort in a large range of people. And they're precisely the same sort of patterns. And we found links between the distortions people see in these patterns and the headaches they have. So that if you have a headache on one side of the head, then you tend to see distortions on one side of the visual field, intriguingly. But that then got me thinking that maybe some of the reasons you get headaches and distortions when you read is because of this sensitivity to patterns.
So I'm kind of intrigued. When you first looked at the photoepileptics that had seizure activity with flicker, pardon the pun, but when did the light bulb go off that black and white lines might do the same thing?
Well, it was a patient I was asked to see, really. She was, at the time, thought to be a very, very rare case. And then we discovered that if you actually test people who are sensitive to flicker with patterns, about 30% of them are also sensitive to patterns without necessarily realizing it. So that led us to study the patterns that they were sensitive to. And as I say, that led eventually to text.
Right. Because I frequently use the pattern that you've created, right? When I establish with someone that this is one of the worst things on the planet for them to look at, the pattern glare test. And then I will pull out a textbook and say, look, if we strip away letters and words and language, at the end of the day, print is just made up of black and white stripes. Yes. And that's when they have this big aha moment that maybe that's why they don't like reading.
Well, it's one of the reasons, certainly. There are all sorts of reasons, and reading is a very complicated process. And we can do a lot to make it easier for people by reducing the types of stripes that they have to look at. So, for example, I mean, there are all sorts of ways in which we can improve text, but one obvious way is to increase the spacing between the lines of text, because that reduces the strength of the pattern, because you've got fine lines with a large space between them, and that reduces the power in the stripes. Another thing you can do is to use a font that doesn't have regular vertical lines making up the letters. So if you use something, a font like, for example, Google Open Sans, which is an open font, so you can alter it if you want to, that also helps. You're getting rid of the vertical stripes from the letters. So both types of stripes are important.
Well, that was really interesting to me, because in preparation for the talk today, I had reread a couple of articles that you were a co-author of, and it occurred to me that it's exactly what you just said. It's not just the horizontal black and white stripes of print. No. It's the vertical stripes within the letters themselves.
That's right.
I thought that was fascinating.
Well, typographers tend to make regular patterns. They think it looks nice. Well, maybe it does, but it also makes it more difficult to see what they're writing, unfortunately. And so one of the best fonts I've found is Google Open Sans, but you can do a whole series of mathematics on the text itself, and we can actually use maths now to predict the settings people will choose when they're using iBooks, for example. It's a combination of spacing and font. So it's not just one thing or the other. All these variables coalesce, combine with one another in text. So you have to use an algorithm that sorts them out. It's fascinating. We have two simple algorithms now that will, first of all, say how quickly you can read the text, and secondly, say how comfortable it is to do so. So we're getting somewhere at last.
Fantastic. I've got a list of questions to ponder with you.
Go ahead.
And we'll kind of wander through them and see how we shape this up in the next 20 minutes or so.
Sure.
So I would like to start with, what is visual stress in the context of the pattern glare that we're talking about?
Visual stress, to me, at any rate, is visual discomfort from patterns. And it's become a term that's used to refer to that sort of discomfort that's alleviated with tints, but it doesn't necessarily have to refer to tints. What does it arise from? Well, I think it arises from problem in the visual cortex, a hyperexcitability, which you get in migraine. And that's, I think, one of the bases for visual stress.
Well, and that leads me to my second question, which is, for our listening audience today, I'm curious to have you elaborate on the term cortical hyperexcitability.
Right. It's a theory.
That's all right. We got to start somewhere.
Well, obviously, in epilepsy, the cortex is hyperexcitable. And in migraine, too, to an extent, because not only are they sensitive to the same visual stimuli as cause seizures, but also there was an early experiment done where they stimulated the brain of people with migraine with a magnetic pulse, transcranial magnetic stimulation it's called. And when you do that, you can see phosphenes, you can see flashing lights. And the strength of stimulus needed before people reported phosphenes was lower in the case of those with migraine, suggesting the brain was more easily excited. And latterly, people have started looking at the size of the response you get in the fMRI, the magnet, basically. You can get a large blood oxygenation level-dependent response to patterns. This was work by Zhe Huang and co-authors. They show that in migraine, response is much larger than in people who don't have migraine. So there's a number of convergent items of evidence. Also, some of the anti-epileptic drugs are also anti-migraine drugs. That's not strong evidence, but it's consistent with the idea that the brain is hyper-responsive and a little bit too excitable, if you like, in migraine.
There was a professor out here at Johns Hopkins University a number of years ago who wrote a book called Heal Your Own Headache. And one of the things that I thought was really fascinating about, in simple terms, he listed at least 5 factors that you had to manage on an everyday basis: stress, hormones, light, odors, and food. And if you think about each of those factors as a telescope that we could lengthen or shorten, well, you've got to shorten as many of those factors as you can, and ideally leave them then the average below your headache threshold, right? And so if the average of those 5 factors got above your headache threshold, you're getting a headache.
That sounds very sensible. Yeah.
And one of the things, and I've got actually 5 little mini telescopes, if you will, in the office, and I will oftentimes pull them out, and we'll talk about the 5 factors, and then I'll take the one little telescope that represents light, and I will oftentimes stretch it out as tall as I can and say, in many cases, this light trigger is enough to drag you above your threshold, regardless of how you're managing the other factors.
Mm-hmm.
So you're right. The idea of cortical hyperexcitability is easy to define, but why it happens, of course, that's the million-dollar question.
It is indeed. I don't know the answer.
But it's wonderful that we've got some tools by which to manage it, though, and arguably it is pretty powerful. So let's transition over and have you talk a little bit about the intuitive colorimeter that you were, I think, really the creator of.
Yes, I nearly set fire to my garage, actually, here. Because light can be quite hot. But anyway, that was in the days when you created it from a hot wire rather than electronically as now. But it's the instrument's gone through 4 rebirths, basically. I discovered that some people seem to like color. So I thought, well, we need to give them the chance to select any color and to do so in a way that was intuitive, a way they knew how to adjust the color. I started off, you see, with a red and a green and a blue light, and you could mix them and get any color. But you couldn't do so in an intuitive way, because if you want yellow, you have to mix red and green. So I was looking at the spotlight in my kitchen one day, and I realized that you could build this instrument fairly simply with a disc that had 3 sectors, 1 red, 1 green, 1 blue. And if you shone a light through the middle, you would have white light from a equal mixture of them. And if you shone it through not the center, but to one side, then you would get light of a stronger color. That was how the original instrument was designed, but we improved upon it later in order to get the same spectral power distribution, the same energy at each of the colors of the rainbow from within the instrument as you got when you were wearing the lenses. And that instrument was designed with a cylinder, basically, around which were all the colors. And that was on one half of the cylinder. The other half of the cylinder was all gray. And the light was in the middle of the cylinder, and you shone the light through the cylinder and into a box where the light was mixed up. And by rotating the cylinder, you could change the color from red to turquoise to blue and so on. And by pushing it along its axle and admitting more of the gray filter, you could change the saturation and the strength of color. And that's the way it worked until recently. Now we've got LEDs. They can be switched on and off by computer. And the whole thing is done electronically from a computer program. But in essence, the technique that we developed for testing people is independent of the instrument. Basically, you start off with white light, you increase the strength of color, and then decrease it. Then you change the color and increase its strength and decrease it, bringing it back to white each time, so that you're comparing each of 12 colors with white, finding the best of those. And then having shortlisted the best colors, you then allow the patient to vary the strength of that good color. And then they're allowed to change the color a little bit and then change the strength of the color again, so that they're hill climbing effectively, alternately changing the hue and the strength of color, the saturation, and then the hue to get the best possible setting. And then you check the effects of brightness, and then you make up lenses that are the same color as the patient selected. The whole process doesn't take more than about 15 minutes at the outside, and yet you know that they've got the best color that they can, which is quite efficient, really. And then their tint is made up using just 2 dyes, because that's all you need. So the process is reasonably efficient now, and we're beginning to find quite a few conditions in which this sort of treatment is beneficial.
Well, that's the interesting part. So I don't have the intuitive colorimeter, but I've got a briefcase of lenses that are 38 millimeters in diameter so that I can place them into one of my trial lens holders. And I've got them arranged in a briefcase so that they're easily picked out. I've got about 50 pair of lenses, I think maybe 12 different colors, maybe 13 different colors, and typically 4 saturations of each color. And I found that to be reasonably effective. I'm also intrigued by the brain that's hyperexcitable. Seems, at least in my own experience, and I've been doing this for 15, 20 years now, I suppose, that the majority of people that I assess with the briefcase that I'm talking about usually pick something in the blue family. Could be blue, could be purple blue, could be teal, but most of them, probably, 90% or so, seem to pick something in that blue family, and most of them pick a color between a light blue and a medium blue. And every once in a while, I'll get a wild outlier who will pick the craziest blue color that I have. And it's also intriguing where sometimes their response won't be as significant as I would have hoped it to be or expected it to be with one of the blue colors. Mm-hmm. And I've taken to where I show them the briefcase and simply ask the question, hey, when you first look at this briefcase of colors, what are your eyes initially attracted to? And it's interesting to me that when I do that sort of intuitive look at my briefcase of colors, invariably their eyes will be attracted to the color that I oftentimes end up prescribing.
Mm. Well, 2 points. First of all, the fact that they're tending to choose blues probably is a reflection of your set of lenses more than a reflection of them. Because if they're given complete freedom to choose whatever color they will, they choose any color. They tend not to choose purples. They tend, as you say, to choose blues and greens or greens. But anything goes.
Yep.
In our latest work, we looked at people who had migraine with aura, and all the colors they chose were well away from the colors you would normally expect in everyday lighting. They chose strong colors, but the colors they chose were not all blue by any means. They were all over the place. And the second point, it concerns surface colors. Now, when you're looking at a tray of lenses, you're seeing surface colors. You're not looking through the lenses. And we know that the colors you select are very different in those 2 contexts. So the colors you select in lenses are very similar to the colors you select in lighting, but the colors you select on overlays or surface colors are usually very different. very little relationship between them, although the people that choose an overlay color do tend to choose lenses. So there is a relationship in terms of who chooses one or the other, but there's no relationship in the colors they actually choose.
I just want to elaborate on that point for a minute.
Mm-hmm.
So is there a correlation between the color somebody will pick with an overlay that's laid over print versus the lens color that they might choose?
No, not really. There is a very, very weak correlation, but it's so weak that you can't use it clinically. You have to assess their response to the lenses or colored light. That's necessary.
Well, the other thing that I find really fascinating about the idea of an overlay versus a lens, and I typically don't prescribe overlays because, well, one of the main reasons for me is that the only thing that changes visually is the text that's underneath the overlay.
That's right.
You're still exposed to all the ambient light.
Yes, it depends what you're doing it for, but you're quite right. And even if you're doing it for reading disorders, they still can't see the board, without lenses. So, yes, I agree. It's a more useful alternative having lenses.
The other thing that I found really helpful over the years, and I can't even remember where all this stuff's come from. Sometimes I think it is slotted in the back of my brain through the power of the universe. Sometimes it's any number of articles or books I've read, and I've somehow melded it into an outcome. Sometimes it could be reading things that you have published in the past and anything else. But what I'm also particularly intrigued by is that when I'm assessing somebody clinically for color, I'm going to do it in a number of ways and measure their outcomes. So yes, I'm going to use the pattern glare test. Yes, I'm going to have them look at print. Yes, I'm going to have them gaze up to my overhead lighting. And what's also interesting is that frequently, as I'm having them look at my overhead lighting, I'll ask them to take 2 or 3 deep breaths. When they really benefit from the color, their breathing changes, right? They get a larger volume of breath. They get a deeper breath. They get an easier breath. It doesn't feel like an elephant is sitting on their chest as it normally feels. And it will also change their touch sensitivity or their sound sensitivity. It'll change their balance and their gait if we go out and check that in the hallway. And it will frequently immediately release trigger points or knots in their neck and shoulders because they have a chance to relax and not be continuously so tense. So the depth of what these lenses can do is so powerful.
It certainly can be, yes. Well, I mean, they can reduce seizures too. In fact, one of the most successful patients I had was totally nonverbal. And yet you could tell from her behavior when she was exposed to lighting of color she found comfortable. And I prescribed that in lenses and her seizures were greatly reduced. No, there are all sorts of benefits, neurological benefits, and we're just scratching the surface at the moment. But we've recently shown that children with autism, they'll be able to perceive people's expressions better. So they were watching videos of actors and they had to say whether the actor was being sarcastic or not, And they could do that better with their lenses on than with lenses of a different color that didn't suit them. So, I mean, these were all placebo, double-masked studies. So, we're beginning to find out just how wide a range of benefits there can be in the appropriate people. Yeah.
One of the experiences I've had, again, as a clinician, is when I'm having somebody look at the pattern glare grid, I will first have them look at it with both eyes open. And then if they've got a pretty aversive response, right, that pattern's moving and wiggling and vibrating and pulsating, and there's colors and there's discomfort or pain, I will frequently have them cover one eye. And I would venture to say that 85 to 90% of the people who look then at the grid monocularly, it's significantly less.
Indeed. In fact, did you know that the chances of a seizure are very, very much reduced? under monocular viewing.
I don't think I knew that.
So it fits perfectly, yeah.
And granted that how we're practicing optometry over here in the US might be different to some degree in the UK, but are you aware of any research that has looked at visual stress before and after binocular vision therapy?
Well, Bruce Evans has done some work, and he's told me clinically that the original instructions are from the college. You have to treat all the BV problems before you go on to colored lenses. But they're not that independent, and very often the appropriate color will actually mean that the binocular problems sort themselves. So you have to decide whether it's the visual stress causing the binocular problems or vice versa. They can both be causal. So you have to be quite careful in sorting out which is whose, as it were.
I'm so happy to hear you say that, because in my own clinical practice, if I get a significant response with color or prism or low plus lenses or any combination thereof, if it's significant, and the patient knows it because they'll usually ask me, can I take these lenses home? It's like, no, I have to make them for you, but we'll make them. And here's the kind of behavioral surveys that I am going to have you take home, because if I can change your quality of life sufficiently, at the end of the day, if you're happy, I'm happy, right? That's my benchmark. Mm-hmm. So take my questions home, answer them. 2 or 3 weeks after you get the new glasses, I want you to go back and look at my questions again. And if things are markedly better and you're happy with your quality of life, then we're just going to leave things go. But if it's not significant, then know that I've got vision therapy or orthoptics in my back pocket, and we can treat the underlying problems if we need to. So I'm trying to do the best of both worlds. I don't want to hold prism or color hostage as a tool to get them to do vision therapy, but I also don't want to not have them only think that color or prism is the ticket and that there are other ways to treat these items. So that was lovely to hear. To the best of your knowledge, is there any relationship between magnocellular vision deficits and visual stress as we're defining it today?
Magnocellular deficits have been mooted as a correlate, if you will, of some forms of dyslexia, as indeed visual stress has been, but there doesn't seem to be much of a relationship between the two. We've certainly looked at the sort of visual tests that you'd expect to show the effects of a magnocellular deficit in patients with visual stress, and we don't find them. But I think I'd better leave the gate open. I really don't know whether there's a relationship between the two. Certainly the symptoms that have been attributed to one are similar to the symptoms that have been attributed to the other. And certainly there's a strong protagonist of magnodeficits in John Stein at Oxford. But he just uses 2 colors, blue or yellow, and we find that 2 colors are not enough, basically.
As we begin to close out this episode today, I can't help but feel to make this observation. So in rereading one of your articles yesterday, it occurred to me that these patterns that we're talking about, namely stripes, don't normally happen in nature.
That's correct, yes.
Well, I have to at least
apart from zebras.
Yes, exactly. That's exactly what I was going to bring up. I have contemplated for a long time if zebras weren't a trial run at, let's see what happens if we put black and white stripes on an animal.
Well, there have been all sorts of theories about zebras. It turns out, I think, that the one I favor is the latest, which is that there are fewer parasites, flies on them, than there are if you get rid of their stripes. And it has something to do with the motion perception of the little biting insects. But in general, you're quite right. Stripes are an exception in natural images, and we have evolved our brains are adapted to process natural images. In fact, they have a very particular relationship between the size of something and how much it varies. And that relationship we've actually used to predict how uncomfortable something is. In fact, with a simple math formula, you can explain 20% of the variance, which is actually quite a lot in terms of discomfort from a whole host of different images. So it comes as no surprise to me that the brain is wired up to treat the images that it used to see efficiently. But of course, nowadays, the urban environment is full of stripes, absolutely full of them. And they're not very good for us. And I've been trying to persuade architects to avoid them as much as possible. And I think the message is gradually getting across. Unfortunately, though, it's very trendy to use modern software for generating buildings, and modern software produces all sorts of funny images, most of them striped. So we have got some education of those people who design our urban environment. We need to make it less spatially repetitive.
And one last thing before we go, Dr. Wilkins, are there some software programs that would divide a screen into two, and a client or patient can change the color on one half of the screen while comparing the readability of text on the left half of the screen?
Yes, there are indeed. They emulate the process of using overlays. But the trouble with them is you get the color of the overlay, if you're lucky, not the color of the lens that you need. They're very different. And the problem with all of this is that there are no good software algorithms for searching in an unbiased way for the optimal chromaticity, the optimal color. The colorimeter does that, provided you use it successfully. But it does involve careful selection of a large number of alternatives and allowing the continuous variation of saturation and then the iterative manipulation of saturation and hue to find the optimal. And I think that's the key to this, really. You can get somewhere with lenses, certainly, but you don't always get to the optimum. And it's quite surprising how precise it has to be. Our latest data seem to suggest the test-retest reliability is of the order of 0.02 for one standard deviation. So if you take people who are susceptible and test them again, they will choose the same color to within 0.02 in the CIE-UCS diagram. That's a way of measuring color, and that's fairly precise. So the benefits of color on reading speed fall away as you move from that optimum, more or less linearly, until they're negligible by the time you get to white. So you can do good, but it won't necessarily be as good as it could be without a good selection of colors and a careful procedure for selecting amongst them.
As we close this out today, one, I want to thank you for coming. It was a treat to have you. So thank you for that.
Thank you. Thank you.
Number two, at the end of the show notes, we're going to list the two books that you've written. I'll include a link to your website and all the articles that you published over the years so people have a good reference to look to. And I would simply reiterate to the listening audience that if you have or know somebody who have a history of epilepsy, migraine, chronic headaches, dyslexia, reading disorder, specific learning disability, autism, ADHD, motion sickness,
Tourette's,
or if you simply get tired, sleepy, bored, lose attention, have trouble remembering what you read, you deserve to be assessed for visual stress and whether or not we can change your quality of life through color.
Right.
Well, thank you again, and thanks for being a guest.
Mark, thank you for your interest. It's been a pleasure.
Thank you for listening to the Move, Look, and Listen podcast with Dr. Doug Stephey. All of the resources mentioned in this podcast and links to learn more about our guest can be found in the episode notes from whichever podcast app you might be listening with. You'll also find a link to Dr. Stephey's website, which is stepheyoptometry.com. That's Stephey optometry.com. You can also call the office at 626-332-4510. We'd like to take a quick moment to thank our sponsor, Audible. If you love podcasts, you'll love listening to audiobooks with Audible. Many of the books mentioned here in the podcast can also be found at Audible. Dr. Stephey has a free audiobook waiting for you as a gift just for listening to the Move, Look, and Listen podcast. Simply click the link in the show notes to audibletrial.com/inbound. Sign up for a free 30-day membership trial, and you can download any audiobook you like. And if for any reason and at any time you choose to cancel your membership, you get to keep all of your audiobook downloads. It's risk-free and for free for 30 days. Support the Move, Look, and Listen podcast by visiting audibletrial.com/inbound. We really do appreciate you listening. And until next time, for Dr. Stephey of the Move, Look, and Listen podcast, I'm Tim Edwards with the Inbound Podcasting Network.